All right, today this video is talking about what to expect when your loved one goes to inpatient treatment. From the internal inpatient treatment facility perspective, what we'll look at as an individual's 6 dimensions from a biopsychosocial level. They'll have an intake, an assessment completed, as well as the ability to rule out any medical conditions that may prohibit them from participating into treatment, and to make sure that those symptoms or medical systems can be managed while in an inpatient program. What agencies do in the state of Washington is work with ASAM assessments, which is a 6 dimension criteria. Dimension 1 is withdrawal management. You want to make sure that the individual is not detoxing off of benzodiazepines or alcohol. A lot of times they come high as a kite, and or sometimes they're bringing in drugs as well. They was court ordered. They don't want to stop. They're externally motivated or pushed into treatment. So they've stuffed drugs somewhere, hid them somewhere. They'll go through a search. All their properties will be searched and sterilized for any bed bugs or any fleas or anything. We get people who are homeless, sleeping out in the street, and they come in, and unfortunately they come in with bugs or things that we don't want to introduce into the facility. And so they'll go through that section. Then they'll have their assessment. The assessment will look at the withdrawal management. We'll look at whether they're on Suboxone, Vivitrol, Subutex, or any type of withdrawal management. They may just be on the kick kit, where the doctor has given them something as far as something for nausea, vomiting, anxiety, those types of things. We would call a kick kit to help them kick the substances, right? To come off of the substances. A lot of times they'll be in active withdrawal, in active detox, or in pause, which is post-acute withdrawal syndrome. Those can last up to a year, where individuals experiencing anxiety, impulsive thoughts, that type of thing. So we'll do an assessment. We'll look in that area. If the individual is coming down off of opiates and needs something, we can get them connected with Suboxone. Really quick, really easy. And most inpatient treatment facilities have a connection with a doctor in the community who is prescribing that type of medications to help the individual. The script to come, it'll be delivered on site, and the individual will be assisted in self-administering those medications. If the individual is withdrawing off of benzodiazepines, there's only a couple benzo detoxes in the state, and the benzo is a mostly an anti-anxiety medication. We're talking about Valiums and lorazepam, clonazepam, and a lot of those PAMs and ENES are kind of the names that are attached to them. They're a subset of medications. So we'll either try to get them into a benzo withdrawal facility, detox facility, but the line is so long, the wait list is so long, it'll probably never happen. So what we do is send them to the emergency room if that's what's needed. Their benzodiazepine withdrawal, their benzo withdrawal will be handled by emergency room professionals and doctors, and then the individual will be transported back into the treatment facility so they can further begin their treatment. If it's alcohol, 9 times out of 10, we can get them assisted in medication-assisted treatment, which is Vivitrol. It helps with withdrawals and cravings of alcohol. Also, research and study shows that it's actually been proven to help with methamphetamine or speed cravings and withdrawals as well. So that's Dimension 1. Dimension 1 will go through any withdrawal. Dimension 2 will look at any biomedical conditions, such as, if the individual has cancer, do they have to leave once a week to go to dialysis or radiation or this type of thing. Sometimes you get folks trying to come into treatment and they have to leave. Well, treatment is voluntarily a choice, a voluntary choice. But to leave every week is a chance for the individual to get drugs. If they're coming off of drugs, they're here for drugs. You don't kind of want to let them run around in the community going to different appointments, right? They'll pick up drugs, they'll bring drugs back in to the facility. So we want to mitigate that as much as possible. But the individual could have, medical issues, or can't get in the top bunk, or can't go up the stairs. And sometimes a lot of facilities only have, upstairs beds available. The individual will have to wait until the upstairs, a downstairs bed is possible, or something like that. So anyway, number two, we'll in dimension two is a biomedical. We'll try to rule out any medical issues that will prohibit the individual from coming into treatment. Dimension three is mental health. Mental health, what we'll do is assess for emotional, behavioral, cognitive conditions and complications, such as, if the individual has a schizophrenia or schizo affective, where they're currently experiencing psychosis, which is audio or visual hallucinations. We want to make sure that we put the person in the room with someone else who's possibly experiencing audio and visual hallucinations. We don't want to cross-pollinate individuals with serious mental illness and individuals with a more garden variety of mental health challenges, because they'll clash, right? This person's trying to sleep. This person's over here responding to what we call RIS, and responding to internal stimuli, talking to somebody that's not there, screaming and yelling at them. You want two people kind of like that together, so they can have the proper frequency, I guess, of pollination, right? Somebody who's more level-headed, who's not experiencing such deep organic brain disorders, is not going to be able to sleep with somebody yelling, right? So we want to put those folks together. We kind of want to look at that. We want to make sure that the mental health meds are available for the individual to take what meds they're on. If we can support that, which 9 times out of 10, we would be able to support those medications. We look at any other behavioral health issues, such as, borderline personality disorder, where there's a lot of emotional provoking, a lot of emotional hijacking and blackmail that happens during this time. We just kind of look at all these issues. And if it's behavioral health, where a person has a personality disorder and their behaviors are maladaptive, or I would say not really accepted by mainstream society. They're a bit different. They behave a bit different. They yell and scream at you when they're talking to you, or they're hostile with their hands, and and a lot of clinicians and staff are intimidated by that or scared by that. Well, we, when I developed that treatment facility, that's the kind of people that we took, right? And so that was dimension 3 is what they'll be assessed in. We'll get all past treatment facilities, how many medications they were on, what worked, what didn't work. We don't want to spend time, trying to manage the individual psychosis with medications that's going to, inhibit them from becoming successful or reaching a therapeutic level, right? So we look at medication history. We look at how many times they've been to inpatient treatment facilities. We'll fax out for those records so we can have a foundation or a substantial a firm ground to stand on when we're trying to make these professional clinical decisions about what should be done with an individual. Dimension 4 is readiness to change. How ready is this person to change? Is this person internally motivated? Do they really want to do it because they don't want to lose their kids? Do they want to do it because they want to be a better person? Are they tired of doing it? Or is the individual externally motivated? If they're externally motivated, then, the court's mandating them to come to treatment. CPS is mandating them to come to treatment. They're being forced by their family. Their family's trying to make them go to treatment. A lot of times those individuals are not successful. It does happen, but a lot of times those individuals are not successful because they're being made to come to treatment. They don't have a buy-in into one. And those are the people that are, a lot of times they bring drugs. They don't want to stop. My mom and them gonna kick me out if I don't quit doing dope. You know what I'm saying? So they want to come in for that, right? And then that, well, we can go into a stage of change as well. Are they in pre-contemplation? Are they thinking about it? Do they want really to do this? So we'll go with internal, external motivation. We'll also go with what stage of change are they in? Are they in contemplative, pre-contemplative? Are they really kind of contemplating it a little bit? Are they in preparation stage of change? Are they really preparing to do this work? They recognize that this is happening and they're really trying to be ready to do this work. And then you have action stage of change. The action stage of change is talking about whether an individual is actually taking actionable steps to, I guess I would say, arrest their substance use. A lot of times when people come in with the substance use and serious mental illness, they could be in, withdrawals, substance-induced psychosis. I guess because coming down off of meth, a lot of times you start to having hallucinations, you see shadow people, that type of stuff. So if an individual is coming into treatment and they're presenting with two different diagnoses, which is co-occurring disorders, this was my specialty, you have to arrest the substance use and deal with the withdrawals from that piece to see how prevalent is the mental health condition, right? Because they both can exist at the same time and you can be confused on what you're actually seeing. So you want to remove one thing, which is the substance use. That's the most prevalent, right? At that time, that's the one that's really in your face that you can see. They're withdrawing, they're shaking, they're really coming off of dope. And a lot of time they don't have no hope. So you got to do a lot of suicide assessments. You got to do a lot of encouraging. It's a lot of work to get this individual to realize that they need that help. And then 9 times out of 10, in our facility, we dealt with serious mental illness, SMI. The individual is already experiencing psychosis, having audio-visual hallucinations, fixed delusions. There's a lot going on here. Ups and downs, mood swings with schizo affective, which is like schizophrenia with bipolar attached. You can have bipolar 1, which is more manic. They're happy, they're bouncing all off the walls, they're angry, and then bipolar 2 is more a depressant. It's highs and lows, both are highs and lows, but you have more of a depressant in bipolar 2. So you want to remove the substance use first before you're actually able to look at the mental health challenges, right? And then you can have underlying personality disorder. So you can have 3, right? You can have a comorbidity, right? Instead of just co-occurring disorders, you can have comorbid features happening at the same time. Polysubstance use, they may be on, 3 or more. They may be on opiates, methamphetamine, cocaine, marijuana, benzos, alcohol. You got to address each one of those substances. It's difficult a lot of times, because they coming down off of one substance, then they have another one that they're trying to come down off of. Those are 2 different experiences, right? And we're trying to mitigate all that. We're not trying. We are. We gonna take care of that, right? So we gonna handle all of that. Then you can see what's going on with the mental health. In Dimension 5, we look at relapse and prior treatment, right? How many times this individual has completed treatment, how many times they have successfully completed treatment, then that lets us know how many coping mechanisms or strategies that these individuals may have accomplished while in treatment, right? So it gives us an insight into the understanding they have of relapse prevention, and then how I guess I would say how likely is it that they would relapse again, right? So we look at that. Dimension 6, we look at the recovery and living environment to see if they have a sober support network, if they, they should attend groups. We recommend that they attend groups while they're here so they can further mitigate and arrest their triggers for relapse, so they can understand relapse prevention strategies, relapse prevention management of themselves. And then at that point, they'll be given more than likely a 3.3 or a 3.5, which means that they'll be living in residential treatment, mostly 60 to 90 days. We did more than 28 days that most treatment facilities provide for individuals. We did 60 to 90 days to give them a better chance. We know the brain doesn't start to heal itself until after 30 days. So to have them hit there for 28 days and send them back, they're still in withdrawal, still in cravings like this. It makes no sense, right? So we do 60 to 90 days. If not, then we'll go up to 6 months. For an individual, and then they go to groups and they learn all these prevention strategies and all these different things that they need to be successful. And that's what it's like to come into treatment with co-occurring disorders. Thank you for your time. I appreciate you for listening.